Thank you, sir. So we'll move on to the topic visualizing a normal angle and how to differentiate a normal angle versus an abnormal angle. So in this session, I try to use a lot of animations as possible. The animations are all made by us to make it more easy and make it more understandable. So this is an animation of a trabecular meshwork that which we have done, and this is an angle anatomy. So basically, the angle anatomy, we can see that the root of iris gets arborized from the root of iris here. This is iris processes. We have the posteriorly the ciliary body band. Then this is the scleral spur, the white structure here, followed by the pigmented trabecular meshwork, the non-pigmented trabecular meshwork, and the corneal wedge that is beautifully depicted by Satyen sir. This is a Schwalbe's line. So once we see the beginners, once we orient them to the animation, now we can take them to the clinical picture. So now they'll be able to see what we wanted to see. For example, once we orient them with this kind of a picture, now this is the root of the iris here, and then the scleral spur is very well appreciated. Then the pigmented trabecular meshwork, non-pigmented. Then we have the Schwalbe's line here. So this is called the metaphorical conceptual learning. So first we show an animation and then teach them how to go about it, and then we put them into the clinical pool of pictures so they'll be able to identify structures better. And this is a grade 3 to grade 4 according to modified Schafer's classification, where you can see all the 4 angle structures are very well seen and visualized. So when in clinically we see this kind of a picture, that means it's an open angle. And then beneath we see a grade 2 modified Schafer's angle, where the pigmented trabecular meshwork seems adjacent to the root of iris. Here the scleral spur nor the ciliary body band, both the structures are not well visualized. And then in this picture, once the gonioscopy is put, so we can see that once the angle structures have been visualized, none of the structures seem to be actually being able to be visualized. So once on high magnification, we can see there is a fine pigmentation alone that is visible, and this is nothing but a pigmented Schwalbe's line. One, if he demonstrates a corneal wedge technique, then it could be confirmed that it's only a Schwalbe's line, and this is none of the angle structures apart from the Schwalbe's line are visible. And this is one of the pictures from Khurana. We have just animated this picture to show the various gradings. So you can see that this is a grade 4, and as you can see, this is now a grade 3 covering the scleral spur, then a grade 2, and then a grade 1. So this is a mechanism that actually happens in grade 4 to grade 0, just an animative video. So I'll just show it to you again. So this is a grade 4 where all the 4 angles are open, and subsequently every angle structures gets covered. So that is all from grade 3, grade 2 and 1, and finally the angle closure. So for patient examination, the patient is made to sit upright. Once a local anesthetic is applied, the lens is positioned into the lower fornix after asking the patient to look up. And an important factor while performing an indirect gonioscopic lens examination is adjusting the graticule of the slit lamp. So this is very important because, as you can see here, the slit lamp has 14 millimeters graticule that we normally use. Now we are reducing the graticule of the slit lamp to as low as 4 millimeters as possible. So what happens is the height of the slit gets reduced, so it prevents any light to enter into the pupillary area, thus preventing meiosis from taking place. When meiosis happens, then the pupil actually pulls the peripheral iris from the angle, causing an artificially open angle. So now a corneal wedge technique is demonstrated to identify the Schwalbe's line. Once the corneal wedge is demonstrated and the Schwalbe's line is identified, now the slit is broadened, and you can see the normal angle structures here, and you can also see a peripheral anterior synechiae here adjacently side by side. This is a beautiful picture showing the normal structures and then a peripheral anterior synechiae side by side. And then the lens can be rotated and subsequent angles can be visualized. And this is an animation made by us about the iris process. As you can see, iris processes are nothing but they are just fine arborizing strands of iris arising from the root of the iris. They just go over the angle recess. They doesn't cause any obstruction to drainage, as well as the obstruction to viewing the angles beneath them is not caused by the iris process. Whereas in peripheral anterior synechiae, they cause an addition to or the addition of the angle, causing obstruction to viewing the structures beneath them, as well as it causes an obstruction to the outflow of the angle, thus causing an elevated IOP and so on. So once we show this animation and prime the neophytes or the beginners, we can now take them to real-time situations where you can see this is how an iris process looks. So once we show the animation Now we take them to the real-time scenarios where you can see the fine arborizing strands of iris coming from the root of iris and attaching itself into the pigmented trabecular meshwork. These are perfectly normal. It doesn't cause any problem like raised IOP or any obstruction to the drainage. And then we have a peripheral anterior synechiae here on the right hand side. So now we show them that this is how it's more broad basal, more dense, more pigmented, and it will be more of a bulky structure which goes and adheres itself to the angle structures, causing an obstruction and a raised IOP. So the important point here is an iris process only wraps around the angle recess. The structures beneath them are very well appreciated, whereas a peripheral anterior synechiae, it just goes and adheres itself, causing a disorganization of the angle structures. And whenever we examine the patient with a Goldmann single mirror or a 3-mirror lens, we need only 3 rotations, 1, 2 and 3, and subsequently we can see all the 4 angles, whereas if we use a Goldmann 2 mirror, then we just need a single rotation to view all the 4 angles. So moving on to the dynamic gonioscopy, we just saw about static now. So in dynamic gonioscopy, what needs to be done is, now the patient is actually looking straight. So the patient is looking straight. So for example, when the patient is looking straight and we are trying to view the angles, so we are trying to see the inferior mirror, that is the superior angle. So when I'm focusing the inferior mirror, the angle appears to be crowded. So ask the patient to now look towards the inferior mirror. You see that opening up, which is appreciated, the angle just opens up. So this is called a dynamic gonioscopy. And I'll just repeat the video once again. The patient looks straight and we are viewing the inferior mirror and the angle appears to be crowded here. Now ask the patient to look down towards the mirror and the angle just opens up. So this is a dynamic gonioscopy performed with Goldmann 3-mirror. And in indirect gonioscopy with these, just anesthetize the patient and just place the lens over the cornea, and simple placement of the lens would suffice in the interpalpebral area. All the 4 angles can be viewed at a single go. So you can see all the 4 angle structures can be viewed. This is an ostium here. So the positioning of the lens can be either an X-shaped or it can be a plus shaped. Both are equally good. It depends on the comfort of the user. It eliminates the need to rotate the lens. That is, a single placement of the lens would suffice in viewing all the 4 angle structures at a single go. But it needs a slight amount of skill level because it uses tear film of the patient as the coupling fluid. More amount of pressure on the eye may just cause some DM folds which may obscure in viewing the angle structures. And in this, as we were talking about the compression gonioscopy or the indentation gonioscopy with a Zeiss 4-mirror lens, so you can see that the base curve of the lens, as Rangara sir rightly pointed out, it is lesser than that of the cornea. So since the base curve is lesser, once we give an axial pressure, so this is an axial pressure, the fluid gets displaced towards the angle. So since the fluid or the aqueous humor gets displaced towards the angle structures widen, thus artifactually the angles may get opened up. So what are the angles that get opened up? So take for example, we use a gonio and we see clinically that the angle seems to be closed. It may be actually an oppositional angle closure or a synechial angle closure. So if it's an oppositional angle closure, with indentation gonioscopy, they open up, whereas with synechial angle closure, they don't open up. And this is a summary, a clinical picture already shown beautifully by Dr. Pankaj Bendale. This is an histological picture of the angle. And then the last take-home point of this session, when you see a normal angle and you examine the patient in 2020, say for example, don't label the patient as normal and forget about examining the angle of that particular patient, provided everything is normal. Keep in mind that the angle is only a dynamic feature and not a static feature. So the eye's gonioscopic status is not static, it is always dynamic. With increase in lens thickness, there is always a chance that anyone can develop a crowded angle in the future. So always keep in mind an increased lens thickness will happen over lifetime, and this may actually lead to a posterior iris contact with the anterior lens surface, causing an acute attack of angle closure during old age. So thank you.